where you are in the world. I'm actually coming to you from beautiful downtown Ottawa, which is very sunny today. And the topic that I'm going to hope to elucidate a little is the issue of private drug plans, insurance plans in Canada. And I provocatively titled this, "Do They Have a Future in Canada?" And I hope by the end you'll understand why I decided to title it as such, why I'm asking that question. I also would like to give you a bit of an apology for being the only person presenting today. You'll probably be rather bored of hearing my voice by the end, but I candidly did not have the time to organize anybody else for this call. I've been traveling around a bit, so so I'm afraid you're stuck with my opinions and my opinions only, but hopefully I'll get some of yours. So as Matt said, our agenda for this call is a bit of a background of drug plan systems in Canada. Some of you will know this, some of you may not. A little bit of a discussion about public versus private drug insurance and the purposes of those, how they're priced, what we do for pricing in these sectors, some of the cost constraint policies and implications that have recently been implemented in Canada for private plans, and some discussion maybe, from my perspective at least, about some of the things we can do if we want to take some action on some of these things, some proposed solutions and recommendations for your involvement. So that's the agenda for our call today. So just as a bit of background, in 2014, Canadians spent an estimated $28.8 billion on prescribed drugs. And if you look, you will see that, in fact, that is by no means the largest spending pot or part of a pie in Canada for the total healthcare budget. So you'll see, for instance, that hospitals are more than double the cost there. Physicians' costs are profoundly more. And if you put together the other health spending and administration and so on and other institutions, they also together amount to much more than what's in the drug budget, prescribed drug budget. So that's just to give you a little bit of context. And another bit of context is that if we look at innovative medicines, that is patented drugs in Canada, they make up just over 66% of healthcare spending in Canada, so 6.4%. With hospitals, physicians, dental care, etc., and total spending in other areas making up by far the lion's share of healthcare spending. And one more bit of context that I think is important for this discussion is the issue of private versus public payers in pharmaceuticals in Canada. So if we look at this slide, you'll see that provincial drug plans, that is public benefit plans, pay out approximately 35.8% of the total spend for prescription medicines, whereas the private sector makes up approximately 58.4%. I think it's very important to take a look at the breakdown in the private sector. It's not all, by any means, funding that is coming out of private insurance plans, but approximately 34.5% of it is, but the other 23.9% is actually coming out of individual people's pockets. Now, this isn't so important for our discussion today, since we're looking at the private insurer side of the pie, but it certainly is an important piece of information as we think about gaps in our drug coverage system generally, and the discussions that seem to be bubbling up about pharmacare and so on. But that's for another day. So let's talk a little bit about the pricing, because this is a very important piece of the puzzle as it relates to why private drug plans have been taking some of the positions that they have recently about the spends that they're having to make and high-cost drugs and sustainability. So in Canada, the first place that pricing really gets discussed in the public sphere is with an organization called the Patented Medicine Prices Review Board. And it's a federal agency, and primarily its mandate is not to set pricing, and it's very important that people understand that. What it's supposed to do is to look at the price which is being proposed by the manufacturer or whoever is going to be distributing the product in Canada. And the question that they're asking themselves is the price that this manufacturer distributor is proposing for these drugs excessive? And that's the language in the legislation. And in the regulations to the legislation, there is a list, or what we call a basket, of 7 countries by which they're to make that excessive pricing determination. And generally, although it's not mandated that they look at the median price for these 7 countries, generally that's what has been happening in the past. And I think one of the important things to note is that in that basket is the United States. And we know that the United States prices generally are higher than the other countries in that basket. And we also know that generally the price in the U.S. is set before the price in Canada. And therefore, that country does go into the excessive, under the excessive lens. And it's argued, and I would agree with this, that does certainly bring up the price in Canada. Although I'm sure some of my colleagues in some of the other stakeholder groups might disagree with that. There have been recently some proposed changes to this basket, but nothing has actually been specifically done. And the Patented Medicine Prices Review Board has recently put out its strategic plan for the years 2015 to 2018, in which they certainly are also questioning themselves whether they ought to be having a somewhat different mandate or some different ways in which they do their work. But the important thing to remember, I think, is that the prices that are approved, not determined, but approved as non-excessive by the Patented Medicine Prices Review Board are what I call, in my parlance, retail or sticker price for the drug. And the important thing here is that those prices generally are paid by private payers, although I do know that some private payers do negotiate specific pricing arrangements that are less than this amount for with some of the companies and for some of their drugs. And even worse, this is the amount that's actually paid by people out of pocket. And of course, those are the very people who can afford these prices the least. So that's the context within which pricing starts to be discussed in Canada. So what are the factors that are considered actually in public drug funding? And indeed, you will see that it has a lot to do with dollars and cents, mostly dollars. So what we do in Canada to determine whether we think that a medication should be part of the spend for our public drug plans, and just a reminder for any of you who aren't so familiar with Canada, that generally drugs are paid for by our provinces, and they make and territories, and they make the decisions themselves. The only things that are mandated through our federal government are payments for doctors and payments for hospitals. So if your drugs, medications, and treatments are being provided for you in a hospital, then they are paid for through that federal mandate, through the Canada Health Act. Otherwise, each province and territory creates its own healthcare budget and administers it and makes the decisions about funding or not funding particular treatments. And the way they do that is that they have, except for the province of Quebec, sorry, I'm thinking of Ontario, except for the province of Quebec, they have come together to create a provincial, territorial, federal government partnership called CADIS. And CADIS has it does the health technology assessment for drugs for the provinces, the territories, and they have a sort of split. They split this between what's called CDR, the Common Drug Review, which looks at health technology assessment and value of drugs for non-cancer drugs, and the Pan-Canadian Oncology Drug Review, PCODR, for oncology drugs. And these are a little bit different in the things that they look at, but overall, they are making the decision about recommending, and it's merely a recommendation. That's very important to note. The provinces and the territories still have final determination about whether to accept the recommendation that's being made to them by CADIS, as to whether they should, in fact, include a particular treatment as part of the public funding lists in each of those jurisdictions. So so CADIS, CDR, or PCODR has expert panels. Those expert panels make recommendations to the provinces, in fact, to everybody, really, the hospitals and even private payers, about decisions. And they, in addition to the evidence base, which they provide, the provinces will look at other non-evidence-based factors. We'll talk about those a bit in a minute. And there will be product listing agreements in many cases. And finally, when we've been through the CADIS Health Technology Assessment Review process, and then each of the provinces puts their lens on that recommendation and makes its own decision, taking into account other factors, then the decision is made about putting something on the public system. I think it's important to note that the Common Drug Review, which, as I've mentioned, is for non-cancer drugs, looks at patient input, clinical and economic evidence to make its decision. As I mentioned earlier, PCODR, which looks at oncology drugs, has a slightly more complex, maybe, approach, which is a formal deliberative framework, as they call it. And they look at 4 considerations, relatively equally in making the decision about recommending something for the public system. So they look at the clinical evidence, they look at the economic evidence, and in that way they're very similar to CDR. They look at patient input, but they do it as actually a quote, equal deliberative process, and they look at ease of implementation of the particular treatment into the existing system. So that's the model that they use. Both of these systems are making a decision about value of a drug relative both to other drugs available for the particular condition that's under consideration, and also relative to opportunity costs of funding this drug versus drugs in other disease or disability areas generally. And generally, they will recommend to the provinces and territories either, yes, we think that you should include this drug on your public funding lists. Yes, you should do it, but only with conditions, which generally refer to a reduction in price, or no, we don't think that this is a treatment that ought to be part of the available drugs for people who have entitlement to public drug coverage. And as I mentioned, Quebec has its own system called INES, which is similar but not exactly the same as the PCODER system. Now, if the Common Drug Review or PCODER recommends a yes with conditions to the provinces, then even if they say yes without conditions, the provinces make a decision about whether to then negotiate a price for the medication. And this is done through a provincial, territorial, and more recently federal initiative called the Pan-Canadian Pharmaceutical Alliance. So the federal government has several plans, two of them, those for Indigenous populations on reserve and correctional services, prisoners in federal prisons, also are negotiated more recently through the PCPA, Pan-Canadian Pharmaceutical Alliance. Negotiations there are done behind closed doors with the manufacturer to find an acceptable price. We never learn, those of us who are not in those negotiations never do learn the price, and I actually don't mind that. Some people do. And I'm sure everybody does the best they can in that room. And then at a time that's determined by each of the provinces, the province will or will not put it on their public drug funding, which is one of the problems with the process, is that even though provinces may come to the negotiating table for the PCPA, that does not require them, at the conclusion of those negotiations, automatically to put a drug on their public listings. They may still not do it or delay doing it until a later date. So that's somewhat problematic, I think. So PCPA has said that it estimates that it has saved $490 million in savings on 63 completed submissions as of March 31st, 2015. So there certainly is some cost savings to that process. So that's the public system. And I just want to remind people that the purpose of the public system is to provide at least a floor level of publicly funded treatments to people who are entitled to public funding for their drugs. And those people generally are people who are over 65 and generally people who are on social assistance. So the gap primarily in the public system to this point has been people who are what have been called in some circles the working poor, people who are working and therefore are not on social assistance, so they're not over 65, although people over 65 can keep working. But they're a real gap. And going right back to the beginning of the presentation, you'll remember that for those gap people, they are paying the PMPRB price, which is certainly higher than the publicly negotiated price. So, and as I also, just a reminder, that the public system is looking at value to the taxpayer of paying for this particular drug for eligible Canadians, and value based on other drugs that are available for that condition, or opportunity cost of paying for that versus another drug in another disease group, given that we have finite drug budgets in each province, and given also that those drug budgets certainly vary significantly depending on the size and economic availability of funds in that province for health. So now let's move to the private sector. There has been some work done surveying benefit sponsors in the private sector about what factors they take into account in designing their private benefit plans. And they're quite different from the reasons that we fund drugs in the public system. And they are primarily intended to be an important part of the benefit plans that attract and retain employees. So they're actually part of your total compensation package, and they make up approximately 25% of people's total compensation package. So the intention here is not to meet, at least originally, was not to mirror what goes on in the public system at all. That's a completely different demographic and completely different reasons for these plans. This is to bring in the kind of talent and to retain the kind of talent in your workforce that you want. So when asked about how they see their benefit plans, a number of employers who were surveyed said that they think it is definitely, they do consider their benefit plans to be very important as a component of their compensation strategy. Many of them consider it to be very important that it reflect practices in their industry, so they want to be competitive with other people who are trying to attract and retain the same kinds of employees. A large number of them also believe that giving people good benefit plans as part of their compensation package optimizes the productivity of their workforce. And a smaller number, but not an insignificant number, also say that they, of course, have to deal with union negotiations, and in those unionized environments, the benefits are negotiated as part of the entire compensation package. So that's what we're told employers, plan sponsors think about why they have benefit plans. So I titled this, How Private Are Private Benefit Plans Really? Well, they were, as I said, developed to be competitive, to be part of a compensation package, to attract and retain the level of employees that this employer wants to have in its workforce relative to other competitors for those types of people. That there is no question that there has been shifting over time for these plans to become more flexible and recognize that they do have different demographics within their employee populations, and with those demographics come different employee needs. And so there has been an attempt, certainly over time, for these plans to become more flexible. In the way that they determine whether or not, they, meaning the plan sponsors, determine whether or not they are going to put a particular treatment in the plan design as part of this compensation part of their package, is through the use of advice from benefits consultants and the insurance companies that provide them the services. Most benefits plans, drug plans, are what are called administrative services only contracts with insurance companies. What that means is that the insurance company administers the claim by the employee for a particular reimbursement for a drug they purchased. So they get an administrative fee for that, but the actual cost of that drug is not being paid by the insurance company, but indeed is being paid directly by the employer, the plan, also called plan sponsor. There are also other contracts which are truly pure insurance, but they are a significantly smaller percentage. And in those cases, the risk, and so in the administrative services only type contracts, the risk is really with the employer because they're going to be paying. So whatever they put on the list is actually to their risk, whereas with these full service contracts, the risk goes to the insurer. So the way they make these determinations is by an internal committee at the insurance company level to determine which drugs and which biologics to cover. So they're not, to this point, they have not been relying on the public health technology assessment approach, which makes a lot of sense since these plans are for a completely different purpose. The plans generally have been fairly open until recently. That is, have covered many things and are generally relatively generous. And that again reflects the desire to use this as an attraction mechanism for employees and a retention mechanism. So things, though, are changing. And we know that for new, I'm going to go 2 slides ahead, for new drugs approved for sale by Health Canada in 2012 that were eventually covered on at least one private plan and at least one public plan, evidence says that private drug plans took approximately 143 days on average to approve coverage, compared to 316 days for public drug plans. This is a significant difference in the amount of time it is taking for people who have illnesses, diseases, and disabilities that require treatments and have private coverage than those who have public coverage. And this is a very important fact for us to keep in mind as we continue and see what's changing in the private system. So, are private plans still these early adopters? That is 143 days versus over 300 days. Well, there's no question that a number of plans are moving from being managed plans, being open plans, to being what are called managed plans, by which I mean that these plan sponsors, the employers, are making decisions about what they want to cover with, as I said before, advice from their insurers and their benefits managers and benefits advisors. So they are actually not being as open as they were before. And the formal medication review committees are now in place, and they're often part of this decision-making through these in-house committees. And they do contract in some cases, but not often enough, health professionals and some external experts to help them. And they're really concerned about new products primarily, and because there is a growing recognition that we have more new products, both for diseases that did not have any really good standard of care, and also profoundly better drugs, even for those that did have some treatments for them. So there has been for quite a long time now a move from these open plans to managed plans. But recently, things have really changed. And I'm going to mention a couple of companies and what they're doing, which is really quite a move away from what we're used to. So Green Shield has decided, it's one of the insurance companies, has decided that it is only going to pay for subsequent entry biologics, even if the originator biologic will cost the plan the same amount. They are just not going to pay for them. If an employee wants an originator biologic, and they don't want to either switch to an entry biologic if they're already on the originator, actually, I don't think they're forcing people to switch. It's only for people, who are newly getting biologics, or people who are getting new biologics for the first time. You will not, even if your doctor prescribes for you the originator biologic, the company Green Shield will only pay if you agree to accept the subsequent entry biologic, which will be certainly some percentage less than the originator, unless, of course, the originator is prepared to give the Green Shield the same amount, which I'm told some of them have. And when I spoke with Green Shield about why they have this policy, they said that they felt that it was important for them to support and encourage the subsequent entry biologics industry. I'm not actually going to comment on that. You can think about that for yourself. So another couple of companies that have made some fairly significant changes and have really narrowed opportunity for access in the private area are Manulife and Desjardins insurance companies. Now, I'll describe these policies in a moment. When you look at them, remember that they are opt-out policies. In other words, this is what they will insure unless you, as the company, the employer, wants to opt out of this particular policy. It's not an opt-in, it's an opt-out. And if you do opt out, you as the plan sponsor, the employer, will pay more for the insurance. And I can tell you that many employers to this point generally don't know the implications of this policy, what we call a watch and wait policy, until a plan member is impacted. And it's a fairly new policy, so I think there's still quite a lot of lack of understanding or misunderstanding about what this is. But this is actually what is called the watch and wait policy. So it has three parts to it. It starts by looking at what they call emerging drugs. So these are newly approved drugs by Health Canada, and they're drugs that are expected to impose a considerable cost to the drug plan. They are put on watch. And then the second part of this is that a reliable, they say, this is their wording, a reliable third-party review is done to determine the value of these medicines, in part based on the publicly available information from CADA, the Canadian Agency for Drugs and Technologies in Health. And we know what their role is. So what that means is that for these newly approved drugs that they think are going to cost a considerable amount to these private drug plans, what they're basically doing is saying, we're no longer going to rely on our own internal review committees, which you will recall generally have been doing their work in about 143 days. Instead, we're going to hold off until the CADA does its work, which is a much longer process, and I'm going to show you the numbers in a minute. And then we'll then, at that point, decide which of these new drugs we are going to put on our private drug plan. So this has a significant impact on people with serious, life-threatening, and serious chronic illnesses for those people covered through Manulife or Desjardins. Now, I'm going to go back to show you the slide, and this is what I have, what I understand. I do not have this in writing from the insurance companies, so if this is wrong, I will take responsibility for that. But I have been told that there are 6 drugs so far and biologics that have been placed on this watch and wait program, 2 of them being oncology drugs, 2 being hypertension medications, 1 being for cystic fibrosis, and 1 being for rheumatoid arthritis. It's early going, and I fear that this list will probably grow significantly. So there's There's another policy that Manulife has put in place, which is also definitely of concern to those of us who work in the area of systemic access to treatments for patients. And it's the two that I want to specifically point out. They mention their watch and wait plan, which we know about, but they also have decided that if a drug is covered under a provincial public plan, that will be kind of the first payer, and that even if a provincial plan changes its funding, that is, takes something off, disinvests, as they like to say, the company, Manulife, will not automatically assume coverage for the charges that for which the province has disinvested. So this could leave somebody having to pay out of pocket for drugs that they've been taking and have been paid for. The other part of this process that's very worrisome is that they are starting to take the position that where there is what's called a patient assistance program, and these are programs that a number of the insurance companies put in place for people who have serious and life-threatening illnesses and for which there's not presently coverage, that if there is such a program in place, Manulife may reduce the amount that they would pay to deduct the financial assistance that the person who's covered by Manulife is, quote, entitled to receive under this patient assistance program. And many of us are very worried about the implications on patient assistance programs and the continuation of those programs if this policy remains in place. And again, they're talking in their last bullet point about the subsequent entry biologics and the fact that in many cases they will only pay for that lower cost alternative. This, of course, we've talked about it being quite problematic as well. So what will all that mean in terms of time to obtaining necessary treatments for serious and life-threatening illnesses? Presently in the private system, where there are open plans, that is, plans that don't have a lot of conditions attached to them or don't limit funding, the internal committees have been taking approximately 90 days to make their decisions after Health Canada's approved the drug for sale or the biologic for sale in Canada. And then there may be a prior authorization process, which means before you have to ask whether they will indeed pay for this before you go ahead and get the drug and submit. Under the managed plans that we talked about a little bit earlier, the time to decision making presently, generally, in private plans is between 180 to 270 days, depending on the drug, and then there may be prior authorization. The public system runs between 304 days on average for the Common Drug Review and 251 days on average for the Pan-Canadian Oncology Drug Review, and then there's the Pan-Canadian Pharmaceutical Alliance negotiations where those take place, which is in many cases, and then there's the listing decision by the government. So the difference, the average in the province that I live in, for instance, Ontario, for all of that to take place is 524 days, in Ontario, 499 days, in average for Canada, 524. There's a profound difference, I'm sure you can see, between 270 days and 499, and certainly 90 days and 499. And I mean, any of these numbers, it's very clear that the private system is providing access to life-threatening and necessary treatments long before the public system. But now, if the Manulife and the Desjardins programs remain in place, and I hope they don't, then really what we're doing is delaying the access to these plans, to these treatments, longer perhaps even than what the public plans are. Because once those decisions are made at the public level, then it would go back for the private system to make its decision. It could be a very long time. And this, I think, is really one of the reasons why I titled my talk, What's the Future of Private Plans? If the purpose of private plans is quite different than public plans, private plans are intended to be a way of attracting and retaining employees to work for you rather than somebody else, and certainly to work for you rather than just rely on a public system of drug coverage as part of your compensation. How is it even, the question then, it begs the question for me at least, what's going to be the value of private plans in the system? It's certainly not what it was by any means. So all the stakeholders have opinions about why private plans are becoming much more restrictive. Certainly the general argument is that there are many more high-cost drugs than there used to be, that we have many more drugs in general than we used to for conditions where we didn't have any treatments, or that we have much better treatments for some and they're much more expensive. I'm not going to argue that out here on this webinar, but that's kind of what we hear. So they're worried about the sustainability of private plans, and I'm certainly sympathetic to that. I don't want to suggest I'm not. I think we do want our private plans to be sustainable, but we can also be creative about how to develop sustainable plans. And certainly we need to think very seriously before we just do what's the easiest thing rather than what best meets the plan needs and also meets employee needs. So what does everybody say about this? The Canadian Life and Health Insurance Association, I've had long meetings with them, and I've also heard them publicly. They would like to see the Patented Medicine Prices Review Board rules. You remember that's the body, the original body that decides if a price for Canada is excessive. They'd like to see those rules changed. They would also like to pay the same prices as public payers for drugs. They say that they are quite prepared to join the public negotiations. That is the Pan-Canadian Pharmaceutical Alliance, and they've even said, we don't even need to go to the table. We're happy to let the provinces and territories negotiate for them, and whatever price they come up with will be fine with them. They have also, I guess I wonder if I really think that's likely to be realistic, but then private insurers, I asked the private insurers about, well, what are you going to do about the drugs, because there are many drugs that are not negotiated by public payers. They're not in consideration for the public plans. And they conceded that that's going to be a serious problem for them. They really haven't determined what they're going to do about negotiating the prices for those drugs. And they also say that they can't negotiate themselves as a group of private payers with the pharmaceutical industry due to anti-competition legislation. And some people interpret the anti-competition legislation differently, but that's the position that they're taking. The pharmaceutical industry, and there's not really one pharmaceutical industry position. I want to be clear here. There are many. Every company is different. And so but these are some of the things I hear. That private plan prices, some companies say that private plan prices subsidize the lower prices that are paid in the public system. I'm not agreeing, by the way, with any of these positions from any of these stakeholders. I'm just letting you know what I hear. I also hear that if private plan prices go down, public plan prices will go up. Some companies say that, some don't. And that savings from private plan negotiations are not used to reduce plan costs or to increase plan coverage. Not everybody says that also, but these are some of the things we hear from some of the companies. So what has the government been saying? Well, the government's position to this point is, look, we're public payers. We only negotiate for public plans, not for private plans, that they are not in a position, nor do they have the mandate or resources to negotiate for private payers. That's what they're saying to date. And what do plan sponsors and members say about all of this? Well, plan sponsors, who are the employers, rely on their insurance companies and their benefits consultants and their human resources departments, where they're large enough to have those, to manage their plans effectively and to ensure competitiveness. And recently, there is an annual survey that Sanofi does of plan sponsors, and they just unveiled it a couple of days ago, and that still seems to be consistent, that plan sponsors want to be competitive, but they also want to be there for people with serious health conditions. And plan members, they recognize that plan members' needs are different depending on their demographics, such as age and marital status and health status. And certainly there's a recognition that small and medium-sized sponsors can afford much less generally than large employers. So one size will not fit all. In fact, one size doesn't really fit anybody very well. So there's a recognition of all of these things, but the plan sponsors are still relying heavily on their insurance companies and benefits consultants and other pundits to give them good advice on what their plan should look like to meet the needs of their employees and also to do what they say they want to do, which is to be there for very sick people. So what's the future? This is my prediction, that private plans are going to continue to become more like public plans, prohibiting access and moving things onto public plans and endeavoring to negotiate pricing in conjunction with the public plans. I'm not sure that they actually will do that, but I suspect they will find a way to endeavor to get the prices that the public plans are getting. Public plans will have more pressure placed on them to provide funding for drugs as private plans divest. Public plans will be less sustainable, therefore, and will cover fewer treatments and place more restrictions on coverage as that pressure gets shifted to them. Drugs may well take longer to get through the Pan-Canadian Pharmaceutical Alliance as a result, and individuals will get less overall coverage and will pay even more out of pocket than they are now. And I've given you some of my reasons for that, the new policies that some of the insurance companies are putting in place, the Canadian Health and Life Insurance Association, Life and Health Insurance Association position, and even the Patented Medicine Prices Review Board strategic plan all lead you to think that. So in the last minute or two, what can we do? Well, we can educate insurance companies, which many of us are trying to do now, and offer to join in developing solutions that are more constructive and will lead to better access for those most in need of expensive drugs. I think we also need to help educate benefit consultants who provide advice to both the insurance companies and the plan sponsors to assist them in thinking about suggesting more constructive solutions. I think we need to educate plan sponsors directly about what is being offered to them by these insurance companies, and also offer to help them educate their employees, because one of the things they say to us is we don't know how to sort of talk to our employees about the fact that we have problems with sustainability and high-cost drugs, and that maybe they're going to have to give up some drug coverage to get other drug coverage. I think employees can hear that message. We just have to deliver it properly. Certainly you should talk to provincial and territorial politicians and bureaucrats, as well as federal, about your views about what's going on in the private system and whether it's really the way we want to see our systems go. Talk to CLIA about your views. The Patented Medicine Prices Review Board will have a consultation on pricing shortly. It should be coming out this month. Feel free to respond to that consultation. And also, my hope is that CCSN is going to be able to offer a patient education and awareness summit about drug pricing this fall. We're putting together a proposal to do that, and I think that we're going to be able to do that. And please come to it. It will be open to all patient organizations who are interested in this topic, and it will certainly include discussions of private pricing as well as public. And last but not least, of course, is join us. We're definitely at CCSN joining with other patient groups, not just in oncology, but in other areas as well, to start to advocate in the area of private plan coverage and try to assist to find meaningful solutions that will be good for patient access and also create sustainability in these private plans, which of course we want. So you're most welcome to join us in that work if you'd like to, and this is how you can do it. So now I'm going to turn it over to you if anybody has some questions. So are there, if you have not written in your questions, please do. I see a question here. How does the public and private drug coverage you've described today fit in with pharmacare plan that is being proposed? Okay, so pharmacare is such a loaded word. First of all, everybody has their own, his or her own definition of pharmacare. But if it being proposed, I'm presuming from that you mean by the federal and provincial governments, because they're the ones kind of, you know, championing this at the moment. So the federal government, first of all, if you look at the mandate letter that the Prime Minister gave to his, the Honourable Jane Philpott as Minister of Health when she came in, it said nothing about pharmacare, that mandate letter. It talked about exploring the possibility of a national drug formulary. So that's not, certainly from a patient perspective, that is not what we would say is pharmacare at all. We're looking for something that is a safety net for those in our society who are uninsured or underinsured. That's kind of what we think. However, at the Liberal Convention a few weeks ago, they did endorse pharmacare as part of their platform, but again, I'm not sure we know what the definition is that they mean there. The provinces have gotten together as well under, I think, the leadership primarily of the Ontario Minister of Health, the Honourable Eric Hoskins, also to promote pharmacare. But at the education session that they held about this topic last June, the primary discussion yet again was about prices are too high, costs are too high, budgets aren't big enough, and we need a list that we all agree to nationally as provinces and territories that will kind of be, they say, the floor, but I worry it might be the ceiling for pharmacare. So I think that the pharmacare plan that is being proposed by the federal government to this point and the provinces to this point is not actually going to fill in as many of the gaps that we see, which are the uninsured and underinsured, as we would like them to do. I don't know if that answers your question, but if it doesn't, please answer a follow-up question. I'll try to be more careful. Have union groups or other groups that represent employee insureds developed a position or been active on this issue in Canada, in the U.S.? Can we learn something from this activity? I've been talking with some of the union folks about this, not too many though, I have to admit yet. And the answer is no, that they have not really developed a comprehensive position on what pharmacare should be in Canada. And I definitely think that the union groups are very important to bring into this conversation, and to make sure that they do have a clear understanding of what it may or may not mean for their members, and to ensure that they do, in fact, develop a position. Other groups, the Pharmacists Association certainly has come out to say, yes, we're in favor of pharmacare, but they really have not nailed down a good definition of that from my perspective. I heard them present very recently, and I think they'd be willing to live with a lot of different definitions as long as their fees get included as part of what's paid for in the pharmacare package. In terms of other stakeholders, a number of academics have spoken and written about this. Names like Morgan Law, Danielle Martin, Marc-André Gagnon, these names might be knowledgeable to you. The way they're writing is much more also in support of the concept of some kind of acceptable national list of drugs, which is not necessarily what all the patient groups would consider to be a really good resolution of this issue. So those are the only groups I can think of for the moment. Can we learn something? Well, I think some of us have learned, first of all, that we clearly don't have the same definition of pharmacare, and that many patient groups and other groups don't actually have a clear vision of even what they mean by pharmacare. The oncology and mental health groups got together just last week, and we've developed a vision, values, and principles for that would be lenses through which we would look at any pharmacare proposals that came to us in future from any stakeholders. They're just in the report back from that consultation and decision-making meeting is still in draft, but it's in its final stages, and it will be available to all of you if you're interested in having a look at kind of our best thinking about what lenses we ought to be using to look at any proposals for pharmacare. And we'd be glad for any of the groups on the call who were at that meeting. We'd be more than pleased to come and talk to your groups about kind of what our thinking was and why we came up with those, and see what your positions are. So are there any other questions? I either did a terrible job or a good job, and you think you learned what you need to. Either way, if there are no further questions, we'll close. Do feel free, if you have any further questions after this call, to get in touch with me. I suspect that many of you on this call know how to do that. If you don't, certainly get in touch with CCSN, and they'll direct any questions you have to me that I might be able to answer for you. So with that, I'd like to thank you for joining us today, and we'll undoubtedly be in touch on this topic and others in the near future.
Okay, thanks so much, Louise.
Thank you, Matt.
From CCSN here. Yeah, you did a great job today presenting for us solo. So thanks so much for doing this once again. Now, just for anybody who wasn't on the call earlier and might have missed it, this webinar is going to be available online tomorrow. There will be a full video on YouTube as well as slides, which will be on our SlideShare account, and you'll get links to both of those things in your email tomorrow afternoon. So be on the lookout for that. And also note that this is going to be our last webinar of this spring series. So we will not be hosting any more webinars for the summer, but you can look out for our fall series, which will be starting sometime in the fall. So after the summer's over, we'll start another series of webinars then. So you can look forward to those. But hope everybody has a great summer and a great afternoon today, and we will see you all in the fall.
Thank you.